Hi, my name is Michael Osborn and I'm a haematologist working at the Women's and Children's Hospital, as well as being the lead clinician of the statewide youth cancer service looking after 15 to 25-year-olds with cancer in South Australia. So it's worth thinking a little bit about the blood that we use in the transfusion setting. So I'm hoping that a number of you are already blood donors, and if you're not, I'd strongly encourage you to consider becoming a blood donor, because it's a way that we can contribute to patients who are sick, as well as contributing to the community. So the blood that we use in the hospitals is clearly from volunteer donors. Now this is an old slide where we said that they would donate at the Red Cross, who've recently changed their name to Lifeblood. So I think I'll have to correct that for next year's lecture. Now, what happens with the volunteer donors is that they'll go along to the donation centre and they'll have a unit of blood collected. And what they'll then do is separate that blood out into its component parts. They'll separate it out into packed red cells, into a bag of platelets, and they'll separate it out into plasma, which is then used either as fresh frozen plasma or as cryoprecipitate, and sometimes it's also utilised for the production of things like immunoglobulins, albumin and factor concentrates and so forth. So in our case, where we've got a patient who's bleeding out, it's worth asking ourselves the question of what product does our patient need? Does he need whole blood? Does he need packed red cells or what? So I think that the answer here is packed red cells. But as we said before, don't forget that in massive transfusion, sometimes patients would also benefit from having some platelets and plasma as well. So why then do we separate them out into their component parts? One of the main reasons is that different patients in different clinical settings need different products. And because blood is a precious commodity that we often don't have enough of, it makes more sense to divide it out and give people just what they need rather than giving all the components to everybody. And that also makes sense in that if someone's got plenty of platelets already, why would you want to give them whole blood, which contains platelets, when they've got enough of that? So instead, we try and divide up the blood into its component parts and then transfuse it in a rational fashion. Now, in many aspects of medicine, I'm sure you would have already learnt that we always need to be thinking about what are the risks of an intervention and what are the benefits of an intervention. And that absolutely holds true in transfusion. In fact, whenever you're going to be transfusing a patient, you always need to be asking yourself, do the benefits of transfusion in this patient with this particular problem right at the moment outweigh what the risks might be to them? So what are some of the risks of transfusion? One of the most important risks to be aware of is that it's absolutely crucial that the right patient gets the right blood type. In fact, if a patient receives an incompatible blood unit, by which I mean a different blood type to theirs, they can have a rapid, potentially fatal reaction to it. And this is the reason why whenever a patient is being transfused, there's at multiple levels checks and balances to ensure that the right blood type is given to the right patient. And certainly over time there's been a number of instances where patients have got the wrong blood type and have died, and clinicians have ended up in court losing their practicing licence and so forth. So it's at many levels clearly not something that you want to have happen. So ensuring that the patient gets the right blood type is one of the most important things to do. There can be some other reactions to transfusions as well, which can range in severity. It's not uncommon for a patient to have a febrile reaction to a blood transfusion, and sometimes they can have an allergic reaction, which can range from some mild itching and hives through to a more full-blown anaphylactic type reaction. Many of you are probably aware that back in the 1980s, there was a big public health problem when HIV first came onto the scene, where a number of patients got HIV from an infected blood unit. And similarly, there's been instances in the past where patients have contracted other infectious diseases like hepatitis from blood transfusions. Thankfully, this is something that's well in the past, in that back in the, I think it was the late 80s or maybe early 90s, the blood service introduced really comprehensive screening. And since screening has come in South Australia, to my knowledge, there's not been any cases of transfusion-associated HIV. Nonetheless, when we're consenting somebody for a blood transfusion, we would always talk about these things, partly because there is community awareness around this, so we need to address it as part of the consenting process. If I was consenting somebody to a blood transfusion, I would probably tell them that the risk of contracting HIV from a blood unit these days is probably somewhere in the region of 1 in 8 million, and the risk of contracting hepatitis from a blood transfusion is probably significantly less than 1 in a million. So really very, very low risks because of the exceptional screening processes that Lifeblood have in place. That said, there's still the risk of getting an infection from another more common organism, such as a bacterial infection or something like that. And with that in mind, Lifeblood also do kind of like a blood culture on most units to ensure that there isn't infection there. It's also one of the reasons why they ask donors, have you been fit and well recently, to try and ensure that somebody who might be bacteremic is not going to be donating a unit of blood. But transmission of infection is certainly something that we need to be thinking about in terms of risks of transfusion. One of the others that's important to think about is the risk of volume overload, particularly in elderly people who might have a degree of cardiac failure already. And there's some other risks of transfusion as well, which you might want to have a bit of a read about after this particular talk. A concept that's really important to understand, and we've touched upon this already, is the concept of ABO blood groups. And I'm sure even back at biology at school, you learnt a little bit about this, but it's probably worth reviewing it in this case. So the ABO blood groups refer to particular carbohydrates on the red cell surface. ABO is the most well-known blood group, but in fact there's actually a large number of blood groups which we know about. So in the ABO setting, patients who are group A, they have naturally formed anti-B antibodies, which means that if you were to give a group A patient group B blood, their naturally present anti-B antibodies would react against that, would cause hemolysis of the group B red cells and potentially kill the patient. In the same way, group B individuals have got naturally formed anti-A antibodies. Group O individuals have got both anti-A and anti-B antibodies, so they can only receive group O blood. Group AB individuals have got no antibodies, so they're a universal recipient. It means that if they ever need a blood transfusion, they could have blood that's either A, O or B, and they wouldn't run into trouble. But clearly this is a reason why we need to work out patients' blood groups and ensure that we're giving the right blood to the right person. When it comes to blood group compatibilities, as I think I've already mentioned, group O individuals are universal donors. So in the blood bank, it's always great when a group O individual comes in, because we know that their blood will be able to be used for many, many different patients. And this is why in the emergency setting, if you need blood immediately, i.e. before you've had time to get a group on the patient, you can use group O blood. Group AB individuals, on the other hand, are universal recipients. As we've already mentioned, they don't have anti-A or anti-B, so they can receive any of the ABO blood groups. So after ABO blood group, the next most important blood group to know about is RHD. Now, in this particular case, in our case rat, Ron Brown with his bleeding peptic ulcer, RHD is probably not going to be so important for him. But there are a number of patient groups where this is quite an important blood group to be aware of, and so it will always be checked when a patient's blood group is assessed in the lab. One of the first groups where we really do need to know about the RHD status is individuals who are RHD negative who have some anti-D. For instance, a lady who is Rh negative herself, who's been pregnant with an Rh positive baby, may have developed some anti-D antibodies. So in that sort of instance, it's really important that she receives Rh compatible blood. In fact, any female of childbearing potential who's RHD negative, you should ensure that they receive Rh compatible blood. And there's several other groups where that's an important thing as well. And the main reason why this is important is that an Rh negative woman who's exposed to Rh positive red cells can develop antibodies against Rhd, and then when she becomes pregnant, her child at around the time of birth can suffer from something called hemolytic disease of the newborn, where the mother's anti-D antibodies cause hemolysis of the baby's D positive red cells. So I think one of the really crucial concepts in blood transfusion is that we always should give the right blood for the right patient for the right indication. And if you think about that every time you're doing a transfusion, it's hard to go wrong. So at a practical level, there's a number of things that are really, really important in order to do this. And one of the first things, well, it sounds obvious, is checking the patient's details. Because clearly what we don't want to do is rush in, think, oh, this is the blood for this patient, and give it to them and inadvertently give the wrong blood type. So it's crucial to check the patient's name. And it's kind of weird going up to a patient and saying, can you tell me what your name is, when you've just had a half an hour conversation with them beforehand. So what I would often do is say to the patient, can you please spell your name for me? And that's a way of checking their name without seeming a bit dumb about it. Then what you would do is check that there's a correct label on the tube and the request form. So as someone who works in the lab, if we receive a request form for a blood transfusion and receive the blood sample with it, if that sample has got a mismatch of the patient's name, so patient's name spelt one way on the request and a different way on the tube, or some other discrepancy, we're going to ring you up and say, I'm sorry, but we can't accept this. You're going to need to take the blood again. And as a clinician, that can be pretty frustrating, particularly if it's just been really difficult to get blood out of these spidery little veins on the patient. So always ensure that there's the correct label on the tube and the correct label on the request form, and ideally don't pre-label your tubes, because it's very easy if you pre-label them to then be distracted, put them down, go and do something else, come back and inadvertently mix them up. So pre-labeling tubes is a bad idea. Probably one of the most important messages at a practical level is that you always need to sign and date your sample. If you send us in the lab a blood tube for a group and hold and you haven't signed and dated it, we're going to be calling you up and saying you need to do it again. And unfortunately, there's no negotiations in that. So any unlabelled, incomplete, mismatched or unsigned samples will be rejected by the transfusion lab. So if you want your intern year to go smoothly, remember this, and it can't go wrong. So what happens once the blood arrives in the transfusion lab? Well, we need to do the blood grouping, checking for the ABO group, checking for the RHD group. And then what we'll do is screen for any antibodies that could be present, and taking those two things together will allow us to select the appropriate donor blood unit, which we can then cross-match against the patient to make sure that they're going to be appropriately compatible. In terms of the ins and outs of that, something that you can read about if you're interested, and it involves a process called agglutination of red cells. I won't go into that right now, but for those of you who have more of a science bent, you can have a read about it. In particular, what we use is something called the indirect antiglobulin test for the antibody screening, and this is a test where the patient's serum or plasma is tested against more than 2 group O screening cells with common antigens, as in this picture here. And a small proportion of patients will need to go on and have an antibody investigation. With regards to cross-matching the sample, previously we'd do something called a serological cross-match, which is where the patient's serum or plasma was tested against the donor red cells using both the direct and indirect antiglobulin test. Currently, most blood transfusion involves something called an electronic cross-match. Once again, I don't think you need to know the details of this, but it's worth at least us going through what's the process that happens in the laboratory when we're planning on transfusing a patient. One of the most important messages for today is that you should only transfuse in a situation where a patient really needs the transfusion. A number of you might be familiar with this Choosing Wisely campaign, which has come out across a number of subspecialty areas of medicine. And the whole aim of this campaign is to look at practices or investigations that have been historically done in medicine which are of low value or might in fact even harm the patient. And one of the most important ones in the haematology setting is to not transfuse somebody unnecessarily. So there's now really good evidence that unless somebody has a haemoglobin of probably 70 or 80 or less, we probably shouldn't be transfusing them. And similarly, that if somebody could get away with only having 1 unit, you shouldn't give them 2. Now this is advantageous at a number of levels. Firstly, it allows us to use a limited resource wisely, and secondly, you're limiting the risk of transfusion-related complications for the patient. So it's always worth thinking very carefully before you transfuse red cells into a patient. That said, in this guy's case, I think I'd be giving him red cells. It's really important to understand the practicalities of transfusion. When I was an intern, the first time I had to chart blood, I made a complete mess of it because in my day, they didn't teach us a lot of these practical aspects of transfusion in medical school. I would really strongly encourage you to have a look at some of the websites that Lifeblood have put together. In particular, the BloodSafe e-learning website, which was built by South Australians from Lifeblood, is a fantastic way of going through some of these really practical aspects of blood transfusion. And if you don't do it now, you'll probably have to do it as an intern. So good to get wise to it now. Similarly, there's all sorts of great information on the transfusion.com website, also put together by Lifeblood. And of course, we need to have apps. The iTransfuse app is a great one to have on your phone, available at the App Store and Google Play for Android users. And more recently, the National Blood Authority have put out very, very comprehensive guidelines about blood for those of you who are really interested. Might save that for another day.